Hello, I'm Penny, Director of the Q Initiative. Over the next 10 minutes, I'm going to share some thoughts on what we're learning through COVID about how to achieve impact through improvement at a time when that impact is needed more than ever. Last year, informed by the work of the Health Foundation and the Q community, I put forward 3 priorities for achieving more from the passion and ideas we invest as improvers. The last 9 months have both reinforced the importance of these priorities and led me to believe I need to update and deepen my thinking. I've realised there's a crucial 4th priority missing too. This has helped me to think differently about what I should do with the years ahead of me as an improver and how to go about it. I hope it may offer you something similar. The first priority last year was avoiding blind spots and lopsided solutions by bringing together all the skills and perspectives needed for reliable design. While there's so much that's new and unstable given COVID, pooling perspectives and skills to make sense of what to do next becomes particularly important. I think we've seen through Q the appetite and value of this way of working. Yet we've also heard that while you've been using improvement to engage staff, meaningful co-design with patients, service users and carers has been much harder. One reason why many of the innovations that have flourished during COVID deserve stress testing and will need to evolve through further co-design with patients rather than assuming they're ready to push out. What in retrospect I realise should have been much more explicit is that this isn't just about developing services that are reliable and work for people. It's crucial to equity. There's no quality without equity, and reliability is only reliable if it works for all. This means as improvers, we need to look deeper and proactively surface and counter inequalities so deep-seated that they may have become invisible to those not directly affected. Otherwise, the only thing we can rely on is continuing injustice, eating away at the heart of public services founded on a vision of equal access. Now, Q has been built around the idea of valuing diversity, but I'm challenging myself on whether the easy and engaging language of bringing together diverse perspectives risks only washing over the surface of what's needed to create a genuinely equitable and inclusive health system. To be leading the way on that, as I believe we should, we also need to ask ourselves whether the improvement movement, those tasked with convening and building solutions from these different perspectives, is a place where everyone can thrive. Improving equity in the health system is one of those challenges that has been with us for some time, but COVID has thrown into stark relief. This is a sort of knotty, critical challenge that we can only tackle through mainstream action at all levels of the system. Which takes me on to how we need to update the second principle I shared last November. Now, I've been working in the health sector for 20 years this year, and a dysfunctional dynamic between the centre and the front line has been a pretty constant source of complaint over that time. Policymakers or leaders at the top of organisations dictate solutions without really understanding what's needed to deliver change. Those at the front line resist or at least fail to deliver solutions with the scale and pace needed for the size of the challenge that's only too visible if you're responsible for a whole organisation, region or country. COVID has shapen up both perceptions and reality. We've seen glimpses of a different pattern. Top-down clarity with bottom-up agency, as we coined it in a recent Health Foundation report. I've been lucky enough to spend the pandemic trying to keep track of and learn from the dizzying array of innovation across the UK and Ireland, with the opportunity to follow deeper the rapid adoption of video consultations, surely one of the exemplar shifts in services during COVID. Through that work, we've heard people describe at organisational level how governance and practical issues that might have taken months to resolve were addressed within days, and how this was unlocked by enabling actions at a national and regional level. Now, when I included this priority for increasing our impact last year, I was conscious that it was a perhaps over-optimistic, a stretching challenge to a deep-seated system dynamic. A year on, I think we're holding a precious opportunity to point to and embed a different, more aligned way of operating. Within our grasp, if we only avoid reverting to the comforting stance of assuming the power to address this lies elsewhere. As improvers, we can play a key role in helping people see and improve the whole system. And it's great that Q is increasingly working at multiple levels. For example, we've been able to bring together leaders at a national level across the UK and Ireland, and we're pushing ahead with Q Lab Cymru, an ambitious attempt to take some of the exciting learning from Q Labs on how to tackle complex challenges and embed it within a structure with reach across Wales. Now, my light bulb moment with this one is that clearer alignment of priorities and direction between the top, middle and bottom of the system is what unlocks the lateral collaboration across teams, organisations and sectors that I think we've been seeing more of during COVID. These quotes from Q's Rapid Learning and Improvement workshop series give a sense of a pattern that could have profound potential for breaking through long-standing barriers to more integrated care, for example. The ability to collaborate and align action both horizontally and vertically is crucial to some of the big challenges confronting us: the massive backlog of patients waiting, unmet demands, and the need to support a workforce already pushed to the limit. And it's also essential to scaling and spreading specific good ideas from one place to all those that need them. And this brings me to the third of the priorities for increasing our impact that I shared last year. The response to COVID has seen a proliferation of people developing and sharing ideas in organic ways with no time to let the standard structures get in the way. As the scale of innovation and the challenges facing the system emerge, there's an understandably strong desire to capture and roll out what seems to be working. This makes this a crucial moment in the history of healthcare improvement to be demonstrating alternative models of scaling and spread. Approaches that recognise the limitations of a pilot and push out model and recognises the role of peer learning and sharing as an essential part of the inevitably iterative process of adapting and adopting new ideas. We know that the model of identifying solutions centrally, then dictating that for adoption everywhere, doesn't work. The alternative I'm describing also has had a credibility gap, especially for those not immersed in and convinced by the power of networks. This is partly because the causal chain is less neat and direct, but also because we haven't always used peer networks when tackling the really critical issues. And frankly, we often don't give these organic mechanisms of spread enough time or attention. We perhaps feel slightly guilty about the time we invest in them. And so they become underpowered relative to their potential. And during COVID, we've seen people, even at the peaks of operational crisis, investing proper time to join sessions, learning from each other and demonstrating genuine curiosity to pull in ideas that can help them. This is the year when the concept of learning systems came into focus, including as a model for spread. QMIBers have been and will need to continue to be at the forefront of this work. Now is the time to think how we'll tell the story and remind ourselves and others that even when operational pressures are intense, indeed, particularly when they are, taking time to learn with others is core and legitimate work. Part of our responsibility to make sure we're focusing the time and resources available to us on the things that are most likely to benefit those we serve. Please use your time at this event as the precious, serious work time it is. And if you can, share the difference this is making so that we can help each other build the evidence base for time invested in peer learning. So that's a quick summary of how we might update our thinking on 3 priorities for collaborative improvement, given what we're learning. I want to move now to what I've realised is a 4th key principle and priority that I think makes the difference to unlocking the others. One thing that's happened since March is that there's been one thing happening since March, a big, terrible thing that's touched every aspect of our lives. We've reprioritised ruthlessly, including much of our healthcare improvement work to focus on COVID. While this narrowing has meant pausing precious and important work, it's also creating a system-wide natural experiment in what happens when you have radically fewer priorities. And I think we've seen that unlock a focusing of energy and collaboration, and that improvement methods and mindsets have been pulled into the slipstream of the central work that teams and organisations are doing. We've been picking up that the COVID response has been associated with both greater collaborative learning and increased use of improvement mindsets and principles, if not always rigorous methods, in places where it might have struggled to gain traction previously. Now, I don't want to overstate or idealise this. We know from the feedback we've had from members and from our Q Insight survey of improvement during COVID that it isn't always feeling like this. These quotes are from the early stage of the pandemic, and there's some sense that this initial energy and focus has become strained over time. And of course, nobody would wish for the all-consuming, terrifying focus on COVID in the first place. But I do think we should take proper time to reflect together on what the pandemic response at its best is showing us about collective focus, certainly before the point at which we decide which of our pre-COVID work programmes should step back up and in what way. The health sector is facing challenges that need a scale of joined-up response that I think call on us to get serious now about prioritising and collaborating. COVID has both required an unprecedented operational prioritisation as a system and calls on us to focus on the bigger impact underlying issues thrown into relief by the pandemic. The breadth of things Q members were working on pre-COVID was inspiring. There will always be a need to incrementally improve quality and safety across the thousands of processes that make up health and care, with all the creativity and diversity of ideas and passions that make up a mature discipline. And there will always need to be space in Q for the full breadth of work happening to improve care. Yet, if we don't make a more coordinated contribution to the bigger challenges facing health and care, our work risks falling well short of what's needed. And improvement will be to the side rather than the mainstream force for good that it can and should be. The health system is facing a huge backlog of patients, set against a backdrop of trauma and exacerbated inequalities in the things that we know determine health. Long-standing challenges with recruiting staff and making the best use of staff skills, and indeed the power of patients and carers, mean we couldn't simply increase capacity even if funding were available. So improvement needs to step up. The size of the gap between the future we're facing and the health system we aspire to will not be filled by small-scale quality improvement activity alone, or work on many specific issues understood in relative isolation rather than part of a greater whole. We need to find a way to bring together the perspectives needed to enable ideas to adapt and thrive in many contexts for all. And we need active alignment and collaboration across the different levels and parts of the health and care sector. And then we need to find ways to scale and spread that recognise the need to learn and iterate over time amongst communities of peers. All this is only realistic if we can focus in on shared priorities and link specific, localised work more explicitly to bigger efforts. Now, if you feel convinced or at least curious about what this might mean for our work as an improvement community and as individuals, I guess the next question that follows is what priorities? What would make up our meta driver diagram of things that will enable sustainable, high-quality care where collaborative improvement can make a major contribution? The sort of challenges that cannot be addressed without the analysis and creative redesign of multiple interlocking systems, with leadership that deeply engages service users and staff so that change is owned and shaped by those on whom sustainable success relies, and where there's both the need and potential to build and share a practical evidence base over time about what works. Now, this isn't necessarily a simple question. Looking across the UK and Ireland, there has been for some years broad consensus about the things that make a difference in health and care. COVID has brought certain things into focus and made them more urgent rather than completely changing what we know about what works. However, COVID has also allowed us to see long-standing issues in new ways. We're only perhaps just starting to understand what this pandemic might mean for us and the strategies for improving healthcare long-term. In this sort of environment, not even policymakers or think tanks can reliably see or understand what will make the biggest difference or is likely to gain most traction. Pooling perspectives can come into its own in this sort of destabilised environment, and so that's where we decided to start. As part of the Q Insight survey this year, we asked you what you think the main priorities for the improvement community should be in the future, given what we're learning through COVID. I'm going to hand over to Matt, Q's Research, Evaluation and Insight Manager, who'll share with you the results.
Great, thank you. So as Penny said, this year's Q Insight survey focused on what the role of improvement during COVID has been, and crucially, what this means for the future of improvement. So we heard from 225 members who gave some really rich detail on their experience. And so a huge thank you to all of those who shared that with us. You can hear more about all of the findings from the survey in a pre-recorded session at this event, so please do listen to that and give us some feedback. But today we want to focus on one question specifically, which asked, given what you've seen and learned through the pandemic, which issues do you think the improvement community should prioritise in the future? We provided a list that we'd developed through testing with Q members and consulting with other stakeholders, and respondents could choose up to 3. Now, they could also add another issue if they wished, although very few did, so that actually suggests that it was quite a decent and comprehensive list, I think. And just to be clear, we asked what people's priorities were, so it's worth noting that when selecting them, people may be choosing those that they think should be the biggest priorities for health and care generally, or they may have been thinking about those priorities which improvement can make the biggest contribution to, or a kind of combination of both of those 2 factors. So you can see the results here. And now, although there was a fairly even spread, priorities did emerge. So if we start at the bottom, reducing waste, supporting self-management, prevention and social determinants, and ensuring that the national and regional policy context is supportive were the bottom 4. They're all important, aren't they? And they were a priority for some respondents. But in the spirit of what Penny said about the potential for greater impact at scale by focusing on some key priorities, we've pulled out the top 6, and that's what we want to kind of work through for the rest of the session today. So I'll go through each of the 6 now and just share a few of the wider findings from the survey that we think are relevant to each of these 6 priorities. The top priority, which was selected by 41% of respondents, was working in a more integrated way across teams and organisations. And we heard in the survey that collaboration had increased, and we've heard more widely that greater alignment and integration has been a key enabler of change during COVID. Interestingly, some of the respondents raised fears that this kind of high tide of integration and collaboration may be beginning to recede. Joint second top was introducing digital innovations effectively. I think we know, don't we, that digital implementation has been turbocharged by COVID. And some of the work that we did with Q members on implementing video consultations really stressed that to really ensure the effectiveness and sustainability of these changes, an improvement approach was key. The other joint second top was embedding systematic approaches to improvement within health and care organisations. So this one is of a slightly different order than the others, as it's more of an enabler, isn't it, of delivering other priorities. But interestingly, the survey appears to suggest that those organisations with a well-developed approach to improvement pre-COVID were able to draw on it in a more substantial and strategic way in their response. So in a way, the wider survey results kind of back up its importance. Fourth was addressing inequalities in patient access and the experience of care. Well, COVID's really brought these issues to the fore, but actually we didn't hear a lot of detail on this specifically in the survey, although obviously there's been a lot of wider work in this area. And so it'd be really interesting to hear in the discussions and more widely at this event, what experience people have of applying improvement to this area. Fifth was improving staff wellbeing. And through the survey and other Health Foundation work on wellbeing, we've heard of quite a high focus on creating compassionate and inclusive cultures. And we've heard lots of good examples of improvement approaches being used for this, whether that's getting regular systematic feedback on staff wellbeing, or facilitating really meaningful staff engagement, such as through huddles, big rooms, after action reviews, or applying liberating structures. And sixthly, was enhancing co-design and co-production with patients, carers, and citizens. Our survey respondents reported relatively low use of improvement for this purpose during COVID generally. But at the same time in the survey, there were a few examples of much more proactive and innovative practice to really kind of meaningfully engage patients. And so I think in a way, those few examples of good practice act as a bit of a challenge to the rest of us. And I think probably reflect wider challenges around patient involvement in improvement. I think we know it should be a priority. We have a pretty good idea of what good practice looks like, but the challenge is to really live up to it, embed it, and ensure it happens. So we think that with those 6 priorities, there's a gap between where we are now and where we think we should be as a system. And we also think that improvement can and must play a central role in supporting that journey. And so I'm really looking forward to hearing more from you all in the discussions about exactly what that role can be.